Good day, my dear postgraduate students. Welcome to the second class on the approach to bleeding disorders, in which we shall be seeing the partial thromboplastin type. As we had seen earlier, this is a coagulation pathway consisting of the intrinsic and the extrinsic components merging at the common pathway. There will be a series of inactive to active components that are being formed. 12, 12A, 11, 11A, 9, 9A, etc. along with factor A. And these help in the promotion of the common pathway. 10 to 10A, prothrombin to thrombin, and fibrinogen to fibrin. This also gets stabilized to form a fibrin clot. So this is important. On the other hand, you have got an extrinsic pathway wherein there is a tissue damage. 7 is getting converted to 7A, and along with the tissue factor helps in the promotion of the common pathway. The logistics of any of this investigation is to localize exactly where the fault is. So kindly read this repeatedly. And this is another further development on it, wherein you have got a platelet which gets converted into an activated platelet by the tissue factor. In this one, Graham Beard says that there are two phases. One is an initiation and another an amplification. So the tissue factor along with 7A helps in the conversion of 9 to 9A. And again, factor 10, 10A, prothrombin to thrombin, fibrinogen to fibrin, and then there is a cross-linking and a stabilization. At the same time, you have got the other things. 9 to 9A, 8, 8A, 5, 5. The idea of the partial thromboplastin time will be to measure the activity of the intrinsic pathway, all the clotting factors excluding 7 and 13. The purpose of it is generally to monitor the heparin infusion, to monitor any anticoagulant therapy for therapeutic anticoagulation, and to analyze and elucidate the cause for bleeding. Sometimes we'll be asked to do the test and the test will be unreasonably high, the value, and the patient is on heparin. I would like you people to kindly compare these two. Prothrombin time and the activated partial thromboplastin time, aPTT. So in one, I find that thromboplastin is being added, citrated plasma, to the calcium. As a result of which, you find this is uncoagulated, and when thromboplastin is being added, there is a coagulation cascade that comes into force. This will be the prothrombin time. In this, we will be able to measure the 5, 7, 10 prothrombin and fibrin. On the other hand, there is an activated partial thromboplastin time. Whenever I use the word activation, remember only one thing, kaolin. Kaolin is a hydrated aluminum silicate plus cephalin. This along with phospholipid is added, the same citrated plasma and calcium. And we find that there is the motion. The common pathway comes into action. So this will be important. This is important for assessing 12, 9, 11, 8 and the common pathways. So this for one side, this for the other side. So obviously I will be able to localize where exactly the fault is. So this is the procedure. The blood is decalcified and to prevent clotting to be done before the test. Calcium and activating substances are added. Kaolin activates the factor 12. Also, you find that aluminum sulfate plus cephalin substitute helps in the platelet phospholipid action. So this will be important, these 4 steps. So in this procedure, the blood is decalcified before doing the test. Calcium and activating substances are added. Kaolin activates factor 12. Aluminum sulfate and cephalin substitute the platelet phospholipid. So these are being added, therefore the test is brought into action. The specimen will be the venous blood and it is collected in a blue capped tube. The indications are, there are a panel of coagulation studies as I had mentioned earlier. One, it has to be done along with the prothrombin time. Independently, it is meaningless. For any of the disorders that can be associated with bleeding, medications, physiological conditions as well. Screening for surgical patients, particularly the cardiac patients, not necessary for all surgical patients. Those who are on unfractionated heparin, the normal value is given over here, 25 to 35 seconds. For a patient on heparin treatment, the higher limit can be up to 60 to 80 seconds. This is also done as a screening for bleeding disorders. For example, hemophilia A, 8, hemophilia B, vitamin K deficiency, wherein both prothrombin and partial thromboplastin time are increased. Von Willebrand's disease in severe cases, not in mild cases. They say that even about a few percentage will be sufficient. Therefore, in severe cases, it can be done. Disseminated intravascular coagulation. You will have to do the prothrombin time, partial thromboplastin time, bleeding time, as well as the platelet count. And liver disease. You find that both will be positive in a case of severe. There are some factors which will be interfering. There is a syndrome called as antiphospholipid antibody syndrome. So whenever there is going to be a damage to the tissue, you find that there can be antibodies which are getting formed. This is called antiphospholipid antibody because your cell membrane will be containing the phospholipids. Whenever there is a decrease in the fibrin degradation, and whenever there is clearing of the clotting factors. So what will happen is, whenever there is a decrease in the fibrin degradation, then this will be interfering as well as a loss of the clotting factors. This is the reference. I would like you people to kindly go to it. The interfering factors can be again antiphospholipid antibody syndrome, lupus anticoagulants can interfere with the phospholipids and the aPTT. Coagulation factor inhibitors as well as defective plasma. The aim is to monitor the heparin infusion. PTT is done in all cases except 7 and 13. Please do remember this. Step by step, one goes very far. So we had seen the prothrombin time and the activated partial thromboplastin time. We shall see what happens next.